Hey, Kath, I don't think this is Boston anymore.
They're not dressed for winter.
Hi, everybody. Welcome to the Update in Hospital Medicine 2015, the review of last year's articles. My name is Jeff Greenwald.
And I'm Kathleen Finn. We have nothing to disclose except the fact that we're from Boston. We're both clinician educators and hospitalists at Massachusetts General Hospital. And as you are probably all very well aware, we have had a very tough winter in Boston. We were up to our eyeballs in snow, and it still has not melted.
Yeah, and so at the height of the snow, Kathleen and I took up aerial photography, because for those of you who've never been to Boston, we wanted to show you what it's like. So here's a shot we took. That's Mass General, where we work. And here are some of the other sites that you may be familiar with here in Boston.
So Boston is also very well known for the famous ride of Paul Revere, Matt Damon and Ben Affleck, a gazillion universities, and then there's some things this winter we really didn't want to be known for. So Jeff and I were asked to review the papers from 2014, and so we went to Ovid or Ovid and we looked up all the medical literature and we typed in humans in 2014, and we ended up with over 307,000 articles. So you guys are very lucky we had a bad winter in Boston, because it's amazing how many you can read when you're snowed in.
Now, in fairness, we didn't actually read all of those, and we didn't read every journal. We decided to exclude these journals from our reading. All but one of those is real, by the way.
But then we couldn't agree. We just couldn't agree. And in fact, I'm not sure whose bright idea it was to put the two people together from the same institution to give this talk, because our offices are 3 doors down from each other, and let's just say sibling rivalry is a tame word. We couldn't agree at all, and eventually, to come up with the articles to present to you, it came down to this. So let's just say my colleague over here with a better overhand throw, people actually slip on the ice in the wintertime. So we eventually, for the most part, agreed on 14 great articles that we put into 2 buckets. One that we called Should Change Practice, and these are articles you can take home and actually act on right away. And then there was a group of articles that are really interesting food for thought. Now, granted, there were numerous articles to choose from, and I am sure that some of your favorites did not make the list. In fact, some of my favorites didn't make the list. Jeff, not that I'm bitter. So let's get started. The first paper is an article that is an interesting food for thought, but it is coming your way real soon. So I'm going to start with a simple question. When was the last time the FDA approved a new oral drug for heart failure? Here are your choices. So show of hands, how many people say 2 years ago? 5 years ago? Few hands. 10 years ago? A lot of hands. Or D, oh, give me a break, there's a cardiology trial every year. That's what I would have said. So in truth, the answer is 10 years ago. It was 10 years ago the FDA approved hydralazine and Iserdil for heart failure after the AHEF trial. So this new study, 10 years later, has cardiologists salivating. And in this study, they tested this new combo drug, valsartan and a neprilysin inhibitor, to enalapril in the treatment of heart failure. And they were so excited and so sure of this that they actually called it the Paradigm Heart Failure Study, shifting the paradigm of how we treat heart failure. So my brainiac colleague was like, yeah, sure, neprilysin. I literally said, neprilysin what? So for any of you in my camp, let me catch you up to speed first. So I kind of simplistically think of heart failure as a fight between the kidneys and the heart. And the kidneys are not getting perfused, they're really unhappy campers, and as you learned in medical school, they trigger the renin-angiotensin system, which increases vasoconstriction and helps reabsorb salt and water. Makes the heart a little more boggy, and the heart gets upset. So the heart releases vasoactive peptides like BNP and ANP, and the body releases bradykinin, which causes vasodilation and decreases sodium and water absorption. Now, the hard part with vasoactive peptides is they have a short half-life, and it is neprilysin, an endopeptidase, that actually breaks down these vasoactive peptides. So if you inhibit neprilysin, with this new neprilysin inhibitor, you actually keep the vasoactive peptides around a lot longer. And if you combine the neprilysin inhibitor with something that blocks the renin-angiotensin system, like an ACE inhibitor or ARB, you really do the heart a lot of favor. So that is why they combine the drugs. Now you may ask, why didn't they combine the neprilysin inhibitor with enalapril, right, the ACE inhibitor, because that was the drug they used in the early heart failure studies, the Consensus and SOLVED study. So the problem is both ACE inhibitors and the neprilysin inhibitor increase the body's bradykinin, and that causes significant angioedema. So they were unable to combine the two, and that's why the neprilysin inhibitor is combined with the ARB valsartan. So in this study, they randomized over 8,000 patients to either this combo drug, neprilysin inhibitor and valsartan, or enalapril. They included patients with moderate to severe heart failure, an ejection fraction less than 30%, and a mildly elevated BNP. They were mostly middle-aged men. Again, I don't know why they don't put women in these studies. And they were on the heart failure medications that were very appropriate. In fact, most of them were already on an ACE inhibitor or ARB at a stable dose, which they stopped before they did the study. They did a run-in period to make sure everybody could tolerate the medications. So all of them got enalapril for 2 weeks, and then they stopped that. Then everybody got the combo pill for 2 weeks, or 4 to 6 weeks, and then they randomized them. They excluded anybody who developed hypotension, kidney injury, had a low GFR, or developed hyperkalemia or angioedema. So their outcome was cardiovascular mortality and heart failure hospitalization. And as you can see here, the enalapril group had more deaths and more heart failure hospitalizations than the combo neprilysin inhibitor valsartan. And in fact, there was a 20% reduction in this combined outcome, with a number needed to treat of 21 to achieve it. This was so successful, they stopped the trial early at 27 months because of the significant outcome, especially with mortality. And if I pull out the mortality, you can see that 16.5% of the enalapril group died compared to only 13.3% of the combo drug, a 20% reduction with a number needed to treat of 32 to save one life. It looked a lot better. So in fact, if you look at the drugs that we use to treat heart failure and the decrease in mortality that comes from each of these drugs, this new combo drug falls right about here, 20%. And so it is better than an ACE inhibitor or ARB alone. So safety, how safe was this drug? Well, the profiles were actually very similar. The combo drug had a little bit more symptomatic hypotension, about 5%, and the enalapril group had more cough and more patients stopped the medication, about 2%. So the takeaway, well, this new combo medication, neprilysin inhibitor and an ARB, decreases cardiovascular mortality, reduces heart failure hospitalizations. Now, granted, they excluded all the patients who couldn't tolerate these medications, so the effect we're going to see when we start using this will be a little bit less, because the patients who couldn't tolerate it were not included in the study. However, this is going to be an alternative choice to ACE inhibitors. And the drug is currently at the FDA. It is just a matter of time before it's approved.
I think you're forgetting something.
You're wearing that?
Hey, we're in DC, it's warm here.
Where's your fruity drink? So yes, he did make me forget. So one thing I did forget is amyloid. So neprilysin actually breaks down amyloid. So in the mice models, when they gave them neprilysin inhibitors, the amyloid levels rose, and the poor mice ended up with cognitive deficits. So they're actually now testing, they did not find the case to be in humans, but they are doing a current study right now with this combo drug, comparing it to valsartan alone, and they're measuring cognitive function. So the second two papers you actually may take home, and this may actually change your practice at home. So we'll start with a case, a 50-year-old man with inflammatory bowel disease. He's admitted with bloody diarrhea. And on day 2 of the hospitalization, he develops acute shortness of breath, hypoxia, pleuritic chest pain, tachycardia. You are very appropriately concerned about a PE, and you order the PECT. The creatinine is 1.9, it's his baseline, his GFR is 53, and you get that phone call from the radiologist saying, I can't do the scan, the creatinine's too high. Anyone have that experience? Yeah. Right, so what do you tell the radiologist? All right, fine, I'll get an ultrasound of the legs. All right, I'll get a D-dimer. Or okay, I'll get a echo. Or D, how many would vote for, don't worry about it, just do the scan? So a few brave souls. So contrast-induced nephropathy is a big concern of the radiologists, and all their consensus guidelines always say if the GFR is less than 60 to go ahead and get an alternative scan. Don't give venous contrast. Well, they define contrast-induced nephropathy as a rise in creatinine within 72 hours of getting the CAT scan. But interestingly, in the last 5 years, there's been articles published in the radiology literature saying that we may be overblowing this contrast-induced nephropathy. And in fact, the radiologists are concerned we are withholding contrast from scans that would really benefit patients for an exaggerated risk. And in fact, what we know about contrast-induced nephropathy comes from cardiac catheterizations, where they're given larger boluses of contrast, it's intra-arterial, and it's given through a wire in an atherosclerotic aorta. So the radiologists are beginning to say that perhaps this is a little exaggerated in CAT scans. And there were 2 papers published this year in radiology done at the Mayo that actually provide more support to the idea that this contrast-induced nephropathy in venous CAT scans may be overblown. So what they did was they were retrospective studies. Both articles used the same cohort of patients. They pulled all of the CAT scans, chest, abdominal, and pelvic CTs with and without contrast, done over 10 years at the Mayo. And that was over 1 million scans. They then pulled out the patients who they could get creatinines on, both pre and post scan, and that was largely inpatients, so the patients we actually take care of. They excluded anybody on dialysis and anybody who had more than 1 dose of contrast in the 14 days prior. And they ended up with over 53,000 scans. Now, they divided these patients into 2 groups, those that got a CAT scan with contrast and those got a CAT scan without contrast. And then they pulled all the usual suspects. And these are all the risk factors that people would consider that would increase someone's risk of getting contrast-induced nephropathy or would make a physician decide not to give a CAT scan with contrast. So they pulled all this data on all these patients. Now, if you can imagine, the group with in the contrast CT versus the CT without contrast are not the same. And so in order to compare them, they actually had to do something called propensity matching. You can see the graph here. Along the x-axis is your propensity score. So they basically assigned a score to every patient in the study based on the characteristics I just mentioned. So a score of 1 meant that you were likely to get a CAT scan. A score of 0 meant you were unlikely to get a CAT scan, and they sort of graded everyone between 0 and 1 using all of the characteristics that were on the prior slide. Everybody in the study got grafted. The people in red, the scores in red are the patients who got a CT with contrast. The scores in blue are the patients who got a CT without contrast. And as you can tell, if the 2 groups were the same, the red and blue would be mirror image of each other, which they're not here. So then they went on to do propensity matching by removing patients from this who were dissimilar, and they matched patients only if they had similar propensity scores. So after they did the matching, you can now see that the red and blue are mirror images of each other, and their groups are now similar in their risk factors, and so therefore you can go on to do a look at the outcomes and compare the 2 groups. So the first study's outcome was acute kidney injury, a rise in creatinine of greater than 0.5. They divided their propensity-scored patients by the GFR. So at the top, you can see normal kidney function, and at the bottom, it's on the your far left, it's less than 30. And so in the group that developed acute kidney injury, you can see that in the group that got a CT with contrast, you can see the acute kidney injury rise from 1.2 in the patients with normal kidney function to 14% in the patients who had a GFR of less than 30. So this is the group that got contrast. In the group that did not get contrast, they had the exact same rates of acute kidney injury, 1.3% in the group that had normal kidney function and 14% in the group that had a GFR less than 30. And there was no statistical difference between the 2 groups. In fact, if you pull out the GFR of the patient we just discussed with the PE, 5.8% of the group that got contrast had acute kidney injury, and 6.2% of the group that did not get contrast had kidney injury, suggesting that it is not the contrast causing the kidney injury. So the second paper looked at a hard outcome, 30-day mortality in emergent hemodialysis after getting the CAT scan. So you can see for the entire population, there was actually no difference between those who got contrast and those who did not get contrast in terms of death at 30 days. And when they pulled out the subset of patients who had acute kidney injury, again, it did not matter whether they had a CT with contrast or not. Their mortality rate was higher, but it was unrelated to contrast. So the takeaway from this study, you may hate propensity studies, but the hard part is this would be a tough study to do as a randomized trial. And the problem with propensity is there are confounders that you may not be able to control for. There were very few patients in this study with a GFR less than 30. However, based on these two papers, you could really argue if a CT with contrast would really make a difference to your patient, it really may be worth a phone call to that radiologist and to advocate for giving contrast if the GFR is greater than 30.
Yes, I am wearing this. So I want to begin my talk, part of the talk, with this notable quote. I'm sure you're familiar with it, those of you who have studied literature in medicine. And it's about delirium. It's from one of the notable clinicians of our time. And for those of you from Hopkins, no, it's not Sir William Osler. Not everything comes from him. This one, of course, comes from Prince. Now, if you read through it, Prince has really identified some of the key elements of delirium, right? He knows about the difficulty, how patients feel very weak and have difficulty standing, how there's often underlying infections leading to temperatures, and that sense of, I'm going to explode, that agitation that patients feel when they have hyperactive delirium. And Prince identified these features of delirium, I mean, years ago. This comes back in 1982, before some of you probably were born. So I want to begin by asking you a question. How many of you work in a hospital that routinely screens its inpatients for delirium? Raise your hand. Okay, a few, or you're just too shy to raise your hand. The most common one that's used is called the Confusion Assessment Method, or the CAM. And it's a well-validated, repeatedly studied four-step system. And if you're not familiar with it, let me just run through it. You need two pieces up front of the four. You need an acute onset with fluctuating course, and you need the patient to have inattention or distractibility. Plus, you need either to show that the patient has disorganized, illogical, or unclear thinking, and alteration in consciousness. So you need the first two and either or both of the latter two to make the diagnosis. Now, it's a diagnostic tool, not a prognostic tool, and it begs the question, can we use this tool to help us understand about the prognosis and future of our patients who get delirious? And that takes us to our next article that came out in 2014, and it was a study looking at how we use the CAM that is converted into a score to predict this issue of prognosis. And it used two concurrent studies, two populations. The first was the SAGES trial that looked at perioperative patients, and the second was a medical population in Project Recovery, and both of these studies were in patients who were 70 years or older. They used these two databases to derive the score, which I'll show you in a second, and they used the data from the outcomes of Project Recovery to figure out how well the score correlated with the presence of a poor prognosis. So here's the original CAM, and then they assigned the score values to each, either absent or present, or absent, mild, or marked, and that gave you a score between 0 and 7 on the CAM severity score, or the CAM-S. So what did they find? Well, not surprisingly, those who were more delirious stayed longer in the hospital. I don't have to tell this audience that. Additionally, the cost went up as the delirium scores rose. Now, the durability of this scale, however, was shown in the following data, which is that at 90 days, more patients ended up in skilled nursing facilities or had died. And if you look at just the mortality rate, the data is quite striking. Those patients with high CAM-S scores had dramatic mortality rates at 90 days. I mean, think about it. How many diagnoses do we send home from the hospital, or send out of the hospital, rather, that have nearly a 40% mortality rate at 3 months? And it raises this question of, should we be using this score to begin to identify patients who need goals of care or palliative care services? So what do we take away from the CAM severity score study? Well, the CAM-S definitely correlates with prognosis, certainly in medical patients, and when the other trials' outcomes are reported, we'll know if it works in perioperative patients or surgical patients as well. We know that the CAM is harder to use in hypoactive delirium, just because hypoactive delirium in general is harder to identify. And so this scale may work less well in that population. But for those high scorers, as we've just seen, maybe it's time to think that we need to do goals of care conversations and think about involving our palliative care colleagues or doing primary palliative care discussions with this population. But wouldn't it be nice to know if these high scorers, if there were interventions that we could put in place that would alter that prognosis? And unfortunately, that data doesn't exist yet. We don't have very good treatments that change prognosis. So if we can't treat it, how about if we prevent it? Now, this literature goes back many years at this point, and there's both medicine-based interventions, behavioral-based interventions, as well as in the perioperative literature, some anesthetic-related specifics that we've looked at with in terms of general anesthetics versus epidurals or spinals, specific anesthetic agents that correlate with less delirium. And then there's a number of medications that have been used, including most prominently the antipsychotics, the original ones like haloperidol and some of the newer ones. But these drugs all have nasty side effects in older patients that we'd like to avoid. So is there something new on the horizon? Well, the new kid on the block is melatonin. Now, for many of you, you know this as a dietary supplement that you can buy at a pharmacy or a nutrition store, or we sometimes prescribe it for sleep in the hospital. And just to harken back to second-year medical student, remember that this is a hormone that is secreted deep by a little nubbin of tissue and deep in the brain called the pineal gland and helps to regulate circadian rhythm. We know, however, that from studies that it's altered by some medications and certainly by infections and other stressful events, and that supplementation in ICU patients can restore circadian rhythm. So since that was true, they have looked at melatonin levels in patients with delirium and shown that they are altered, that they're low in patients who are delirious, raising the question of could you supplement delirious patients' melatonin levels exogenously? And that was studied in this randomized controlled trial in 2011, showing quite effectively that melatonin supplementation did reduce incident delirium in medical patients. But as I mentioned, it's a nutritional supplement, which means it doesn't undergo the same regulations that medications do that we use routinely in the hospital. And so there's a new kid, again, named Ramelteon, which is a melatonin agonist. MT1 and MT2 are the melatonin receptors. The MT1 is in the brain, MT2 is in the retina. And it has been approved by the FDA for sleep. And so that takes us to our trial of using it for delirium prevention. In this study, it was a randomized controlled trial at 5 sites. They took older patients who were hospitalized for serious medical illnesses in the ICU or on medical floors. Now, of the ICU patients, they excluded patients who were initially intubated, so those patients were out of the study. And they gave patients either the drug or placebo at 9 o'clock at night. And then they had blinded observers using a validated tool for the diagnostic purpose of identifying delirium. And they followed them out 7 days or to hospital discharge, whichever came first. And their primary outcome, not surprisingly, is incident delirium. It's a small study. Only 67 patients were in this trial. But the results were quite dramatic. Ramelteon in its group only had 1 case of delirium develop, whereas the placebo arm had more than 10 times that. So what do we take away from the Ramelteon trial? Well, it reduces incident delirium quite effectively in medical and non-intubated ICU patients. And though it was a small and short study, we have to remember that these are cheap and well-tolerated, pretty benign interventions. And wow, if we could reduce by, say, 90% the incident delirium in our population, wouldn't that be amazing for all kinds of reasons? And I think we're well poised as hospitalists to begin to develop research studies on things like this to study a larger scale study of melatonin or Ramelteon.
So the next paper actually may get you excited. It's a food for thought paper that may actually get you excited about hepatic encephalopathy. So really, seriously. So 52-year-old woman with cirrhosis due to alcohol and hep C is brought in by her family for confusion. She had stopped her lactulose 5 days earlier. While working up all of the etiologies for her confusion and the causes of hepatic encephalopathy, you order lactulose. But even in her confused state, you can hear her yelling at the nurse, "I'm not taking that bleeping orange stuff." Sound familiar? So what are your choices? So A, you could place an NG tube. B, you could give her lactulose per rectum. C, you could give her magnesium salts. D, you could give her polyethylene glycol. Go lightly, prep her for a colonoscopy. Or E, give her back to the family. So how many for A? Give her rectally, lactulose per rectum. So B, anybody for A? Few A's. How about mag salts? Anyone want to give magnesium salts? How about polyethylene glycol? Few hands. Or give her back to the family? Yeah, a lot of hands. So what are your choices? Well, actually, the study this year looked at polyethylene glycol and compared it to lactulose in the treatment of hepatic encephalopathy. So lactulose we've been using since 1966, and about 20 to 30% of patients don't respond to it, and patients hate it. Ugh. So the theory of hepatic encephalopathy centers around ammonia. We all learned in medical school with a lot of hand waving that maybe lactulose lowers the pH of the colon, it traps ammonia as ammonium, and you poop it out. The other possibility with lactulose is it's just a cathartic. It just moves everything through quickly, decreases transit time. And in fact, the old treatments for hepatic encephalopathy were magnesium salts. They just made you poop a lot, and it was a large decreased transit time. So this new study compares lactulose to a modern-day cathartic, polyethylene glycol. So what did they do? Well, they included patients presenting to their emergency room with hepatic encephalopathy and cirrhosis. They were older than 18. They had any grade of hepatic encephalopathy, and they had to have a legal representative to consent to the study. They excluded anyone if the confusion was not from hepatic encephalopathy, anybody who was on rifaximin because they didn't want to confound the issue, anyone who was hemodynamically unstable, and they allowed patients to get one dose of lactulose, largely because by the time they got to the emergency department to enroll the patient, the ED doctor had already given the one dose of lactulose. So about 80% had gotten lactulose, one dose. So they randomized 50 patients to lactulose, the 20 to 30 grams, they got at least a minimum of 3 doses over 24 hours. And then 25 patients got 4 liters of polyethylene glycol over 4 hours. Yes, they drank 4 liters in 4 hours. I'm not sure I could do that. And they got 76% of them to actually do it. The two groups were actually very similar in age. The degree of cirrhosis was the same. The etiologies of cirrhosis were the same. The BUN was slightly higher in the polyethylene glycol group. And their primary outcome was this HESA, this hepatic encephalopathy scoring algorithm, where grade 0 is normal, which we all right now, maybe not Jeff, but it went from grade 0 up to grade 4, which is coma, with increasing somnolence at all the levels. They measured the HESA score at admission, 24 hours, and daily. And their primary outcome was improvement in this HESA score by 1 grade at 24 hours. And the patients enrolled in this study, the initial median score was 2.3. So these patients were fairly confused. So here's their outcome, the change in HESA score at 24 hours. Each line represents a patient drawn over the 24-hour period. And the solid colors indicate patients who did not change their HESA score. So as you can see, there were a lot more solid colors in the lactulose group, meaning they did not change their HESA score, and it was statistically significant. So in fact, if you pull it out, 48% of the lactulose group did not clear or even change one HESA score. 9% of the polyethylene glycol group changed, much lower. And on the flip side, how many patients cleared completely to a grade 0 at 24 hours? Well, only 8% of the lactulose group did, but 43% of the polyethylene glycol group cleared at 24 hours. And in fact, the reason there's only 23 patients here, not 25, is that 2 people cleared so quickly, 1 left the hospital, and 1 woke up and said, no way am I participating in this. So the curious about it, well, they didn't have to force feed the polyethylene glycol, same number of NG tubes in both groups. Now, polyethylene glycol they were always worried that you're losing potassium, and that did happen. There was a statistical drop in potassium in the polyethylene glycol group. So if we end up using this, we're going to have to monitor potassium and replete it. But the ammonia story is really interesting. In the lactulose group, the ammonia level dropped. Just what we were taught in medical school. But interestingly, it did not drop in the polyethylene glycol group to any great significance, but they cleared more. So this probably needs to be looked into a little bit further. So the takeaway, so for acute hepatic encephalopathy, there is a possibly interesting new treatment, and cathartics work. Now, granted, you have to drink 4 liters of polyethylene glycol. And they didn't dose the lactulose group by bowel movements, and it's a small study. So we can't say go out and do this, but I'm really curious to try it. And the interesting part is that more patients actually preferred the salty taste of the polyethylene glycol over sweet lactulose, and they requested it at discharge. So the second paper going on, this second paper actually is a practice changer. So 52-year-old woman, the same woman you just admitted a week earlier with hepatic encephalopathy, she has ascites and varices, but she's never had spontaneous bacterial peritonitis before, so she comes in a week later now with SBP. Her medications at home included the furosemide, spironolactone, propranolol, and the polyethylene glycol, which she shouldn't have been on, but she really insisted on taking some home with her. So in addition to starting her antibiotics, should you stop her propranolol? So how many say yes? Few people. How many say no? Large group. Okay. So non-selective beta blockers like propranolol are considered the aspirin of hepatologists, right? So since the 1980s, we have known that the non-selective beta blockers work in primary and secondary prevention of variceal bleeds, the biggest killer of patients with cirrhosis. And there are smaller studies that even say that these non-selective beta blockers reduce the risk of ascites. However, in the past few years, there's been growing articles actually starting to suggest that perhaps there's some harm from non-selective beta blockers. In fact, in patients with refractory ascites, refractory to diuretics, there's a decreased survival. And there's been studies now suggesting there's increased mortality in cirrhotics who develop bacterial infections who are on a non-selective beta blocker. So this, in the last 3 years, has led to this theory of the beta blocker window in cirrhosis, where early in cirrhosis, there's really no benefit from a non-selective beta blocker. But as patients develop varices or ascites, the window opens, and there is a great benefit from being on a non-selective beta blocker. But they know as the pathophysiology and the hemodynamics of cirrhosis changes through time, it's starting to look like the window actually closes as cirrhosis gets severe, and that these non-selective beta blockers may not be beneficial. Now, this is still a little controversial in the GI literature, but it's actually starting to be accepted a little more. And the question is, when does that window close? When should we stop the non-selective beta blocker? So in fact, this study this year really suggests it may be when you develop spontaneous bacterial peritonitis. So it was a study out of Vienna. They was at a liver center. They went back and looked at patients from between 2006 and 2011, and they looked at patients presenting to their center with their first bout of ascites, though they excluded anybody who had SBP at the time of the first paracentesis. And they followed these patients through time, looking at medications, whether they developed SBP, death, and renal failure, and whether they went on to transplant. And you can see in this cohort study, the patients on a non-selective beta blocker did have more varices, 90%, which sounds like they were appropriately being treated. Their heart rate was lower if they were on a non-selective beta blocker. Good to know beta blockers work. But the two groups were very similar in their degree of cirrhosis, and they all had fairly significant cirrhosis. Over time, 182 of the patients developed SBP. And statistically, it was actually the same in both groups. So the outcomes was transplant-free survival. So you can see the survival curve here. In patients who did not develop SBP, there was a survival advantage in being on a non-selective beta blocker. In fact, there was a 25% reduction in mortality. So it was good to be on the propranolol, or the non-selective beta blocker. But once patients developed SBP, they pulled them out and they grafted them again. Now you can see the two lines switch, and patients on a non-selective beta blocker have a disadvantage. In fact, they had a 58% increase in mortality if they were on a non-selective beta blocker after they developed SBP. And they think a lot of this may be related to hemodynamics, because their blood pressures and mean arterial pressures were much lower after they developed an infection. When they looked at renal failure, the black bars are the patients on a non-selective beta blocker, and 90 days after SBP, there was a much higher rate of hepatorenal syndrome and acute kidney injury in patients on a non-selective beta blocker. So what this suggests, and it is a retrospective design, so there are issues, and the adherence to the non-selective beta blocker was unknown. They just knew they were written for it, but they weren't sure how much the patients were actually taking, and the doses really varied. But overall, this paper strongly suggests that before spontaneous bacterial peritonitis, there is a benefit from being on a non-selective beta blocker. But after a patient develops SBP, there's actually a strong suggestion that this non-selective beta blocker may increase mortality by 58% and increases the risk of acute kidney injury and hepatorenal syndrome. So in truth, if your patients develop SBP, you really should consider stopping their non-selective beta blocker.
So you all, as members of SHM, know that we do a lot of things. We have political advocacy, we do quality improvement, we do education, we do clinical guidelines. You may not know that we've branched into the world of making television shows. There's now, SHM underwrites CSI Washington, D.C., except there's one minor problem. We ran out of money, and so it's really actually called CSI National Harbor. Now, the first episode of this show is about a crime. And what crime, you may ask? It's about the attempted murder of a sacred cow. And when I say sacred cow, I'm not talking about Larry Wellickson. I'm talking, in fact, about VTE prophylaxis. Now, this study that came out this year looks at VTE prophylaxis in a general medical patients. Now, let me give you some background. The Joint Commission, as you know, and the Centers for Medicare and Medicaid Services have been making us do VTE prophylaxis as a quality measure or a core measure for many, many years, with the belief from early studies that it reduces VTE events in our hospitalized patients. But in 2011, a meta-analysis came out in the Annals that looked at 21 studies of medical patients and 19 studies of stroke patients and was unable to show an overall mortality benefit of this practice. In fact, they were able to demonstrate that they could prevent 3 PEs at the cost of 4 major bleeds. I don't know if that's worth it. But the ACP picked up this PE benefit in their guidelines in 2011 and said that we should be risk assessing our patients, and high-risk patients should be getting medical prophylaxis for VTE and not serial compression devices, those little squeezy boots, because they actually cause more skin damage and don't actually have any benefits. Well, this trial that I'm going to tell you about from 2014 came out of the Michigan Hospital Medicine Safety Consortium, a consortium of 35 hospitals that that pooled data for quality and safety reasons and could then analyze it for research. These are medical patients in this study. They took out the patients who were deemed low risk using what's called the Caprini score, which is a validated score to assess VTE risk. They took out the folks with very low risk. And then they followed patients out to 90 days to look for events. At 90 days, they phone called them and could reach about half. And they also did extensive chart reviews on all of the patients in the consortium. And they also looked at how well did the 35 hospitals in the consortium adhere to guidelines. And they broke them down into the high performers, the middle performers, and the low performing tertiles. Well, they were looking in this analysis for the rate of clinically confirmed VTE. So they were looking at proximal DVT, symptomatic, PEs that were symptomatic, not distal DVTs and not asymptomatic events. And they only accepted patients into this cohort who had events that were 3 days or more into their hospitalization, so that if you came in with a diagnosis of PE or DVT, you weren't part of this cohort. They included almost 21,000 patients across the 35 sites, and in that cohort had 226 events, 2/3 of which were DVT, so 1/3 were PE. But interestingly, for hospitalists, only 15% of events happened during the hospitalization. That is, after we send them back into the world, the other 85% happened thereafter. So here are the tertiles broken down by hospital performance. The high-performing group, the middle performing group, and the lower performing group, but based on how well they adhered to guidelines for medical prophylaxis. Now, in theory, if medical prophylaxis was helpful, then the high performing group would have a lower rate of VTE events than the low performing group. But this was not true. At 90 days, the in-hospital VTE rate and total VTE rate at 90 days were totally awash between the arms. And in fact, when they looked at subgroups, that PE event rate that they saw in the initial Annals article that I mentioned, they didn't see that either. Neither by PE subgroup or DVT subgroup could they show a benefit. And the authors did a number of other subgroup analyses and could not find a subgroup in which the benefit of medical prophylaxis was evident. So what do we take away from this study? Well, there's no clear benefit to medical prophylaxis in medical patients at this point. The data just doesn't support it. Additionally, it's time to really reconsider how these quality and safety metrics that we as hospitalists and hospitals are being measured by governmental and regulatory agencies. But maybe there are, since VTE events still happen, maybe there are better scales to identify who might benefit. If there is a subgroup, we may not know it. But maybe it's time, finally, just to abandon VTE prophylaxis for general medical patients and recognize that this sacred cow is, in fact, dead. How many of you know what this is? There you go. How many of this is the iPhone, the Apple iWatch? How many of you, raise your hand if you would really like to own one of these in the next 6 months? It comes out in about 3 weeks. There you go. So you guys are what we would call the early adopters. The early adopters are the folks who get into the new technologies really fast. And what I'm going to talk about today, of course, is not iWatch, but a different technology, and that is the direct oral anticoagulants, or the NOACs, the novel oral anticoagulants, terms that are interchangeable. And I, personally, have been a little slow to embrace this process. Kathleen, on the other hand, yeah, she's practically off the page as a laggard. Now, I'm going to give you a little PTSD. Remember second year medical school when you studied the coagulation cascade? Yeah, me too. No, I actually don't remember that. But anyway, the drugs that we're talking about work here at factor 10A, and these are the oral 10A inhibitors. And you can tell the rivaroxaban, edoxaban, and apixabans because they all have the XA for 10A inhibitors. If you can't remember them, that's how I remember them. And the thrombin inhibitors, and that's dabigatran. I guess they could have called it dabigathran, but I guess we'd all sound like we're lisping. Those are the 4 drugs that we're going to be talking about. Those are the ones that are currently available and have the best data. But why use them, right? I mean, we've got this devil we know, warfarin. It's, it's reversible rat poison, basically. Or should we use these devils we don't know? The DOACs, right? They're slick, they're new, they're kind of sexy, but they're irreversible, and we all have concerns about the bleeding issues with them. So there have been 3 meta-analyses come out in the last year that are worthy of our notice to help us make this decision. And this is the first one, looking at VTE. So it compiled the data from all of the major DVT and PE studies using the NOACs or the DOACs, and together accrued about 27,000 patients, equally balanced between the DOACs and VKAs or vitamin K antagonists, basically warfarin drugs. What did we learn from this meta-analysis? Well, when it came down to VTE and VTE-related death, the efficacy endpoint, it was a wash. They worked just as well, essentially, or they were non-inferior to the VKA, the vitamin K antagonists. But from a safety perspective, they were actually remarkably safer, not a little safer, a lot safer when it comes to the relative risks. Now, patients, if you ask them, would you rather bleed or would you rather clot? They say, thanks very much, but I'd rather do neither. And that's this last endpoint where they lump all the bad things together. And when you include VTE-related death and VTE and major bleeds and things like that, the DOACs also come out smelling like roses with a relative risk reduction of 21%. When they did subgroup analyses, again, when they looked at the PE patients, the DVT patients, the patients greater than 100 kilos, and those with a creatinine clearance in the moderately low range, not the below 30, but the 30 to 49 range, it was a wash in terms of efficacy. Though in that lower creatinine clearance range, the DOACs seemed to be better from a safety perspective. They were also better from both safety and efficacy perspective when it came to older patients. Cancer patients also seem to get an efficacy benefit, though maybe not a safety benefit in their subgroup analysis. So what do we take away for DOACs and VTE? They're effective. They are as good, and they're definitely safer at this point based on the data. The subgroup analyses also look very promising, so we can use them across a broad swath of our population. But we still don't know what to do with these folks with very low GFRs. And the real study that we're waiting for in terms of cancer patients isn't against vitamin K antagonists, but since the CLOT trial, it's DOACs against low molecular weight heparin, since that's now standard of care. We don't have that data yet, so maybe that's not the right place to use it. But what about AFib? That's the other group we want to look at. So here's that meta-analysis. Again, it looks at the major trials, randomized controlled trials in AFib. In this time, you'll notice that the two arms are not balanced, and that is because the dabigatran trial and the edoxaban trial had three arms, a high-dose DOAC, a low-dose DOAC, and a VKA arm. And so they were not equally balanced. In this meta-analysis, the patients were in their early 70s, big surprise with AFib. With AFib. And these folks had, most of them had a CHAD score higher than 2, though about 1 in 6 was below that cutoff. And they followed these patients out for 2 years. And from these forest plots, you can see that there was an almost 20% reduction in stroke or systemic emboli favoring the use of the DOACs. Well, that's great, but let's make sure these folks aren't doing that at the expense of bleeding. And in fact, that was not seen. The safety profile was quite good with a 14% reduction, which didn't quite meet the 0.05 statistically significant barrier. Again, looking at subgroup analyses, the things we want to prevent, well, hemorrhagic stroke and intracranial hemorrhage clearly favored the use of the DOACs. And I will say that the data that they used for this subgroup includes the high-dose DOAC arms of the dabigatran and edoxaban trials. So that's actually quite promising, because we'd be worried about bleeding. Overall mortality was also favoring the DOACs, and this all happened at the expense of an increased risk of GI bleeding, and that was probably largely driven by the dabigatran data, where there seems to be a bigger issue of GI bleeding. So the takeaways for the DOACs with our AFib patients is they clearly reduce stroke and emboli. They probably overall reduce major bleeding, but as I said, it wasn't quite statistically significant. But there were clearly fewer intracranial hemorrhage and hemorrhagic strokes, but probably also more GI bleeds, and we'll have to be careful and watch for that in the right population. But I think at the end of the day, the real question is, what would I do for my grandmother, right? I mean, no, sorry. This is my grandmother giving me a nice bowl of chicken soup. Am I going to give my grandmother the devil I know or the devil I don't, right? Well, let's look at this, a meta-analysis of these trials looking at just the elderly arms of them, right? The subgroup of 75 and older. They were able to find 10 trials that they could extract data on elderly patients, comparing DOACs to vitamin K antagonists and or low molecular weight heparins. There was only data extractable from the rivaroxaban, apixaban, and dabigatran trials. There wasn't data in the edoxaban arm to show us. So they defined elderly as greater than 75 or greater than equal to 75, and there were about 25,000 patients in the trial. Overall, from an efficacy standpoint, it was a wash. It was not a wash. It was it strongly favored the DOACs with a number needed to treat for stroke of 71 and a number needed to treat for VTE or VTE-related death of 30. These are very respectable numbers needed to treat. There was a big benefit from an efficacy standpoint in older patients. Individually, rivaroxaban and apixaban, they had slightly different study designs, so the language is a little bit different and confusing at times, but overall, they were both very promising, similar to the overall effects that I showed before in terms of stroke, VTE, and death. Dabigatran was clearly effective for stroke, though they didn't have adequate older patient population for VTE and death. Now that's great, again, but let's make sure they're not doing this at the expense of safety. And they weren't. The safety was a wash between the two arms. Major bleeding was the same. In fact, in the AFib and the VTE trials, when you broke them out, again, there was no difference. Individually, there was no difference among the three trials, but I want to point out one thing that is striking about these. Look at the percentages on this slide. We're looking at 4 to 9% event rates. These are much higher event rates than we're used to thinking about in patients who get on anticoagulations who are well managed and often younger. Older patients have higher event rates, but they don't preferentially occur with either DOACs or VKAs. So the takeaway of DOACs for my grandmother is they're clearly as safe, they're more effective, and the best data at this point probably favors the use of rivaroxaban or apixaban in elderly patients. But we have to be mindful of low GFR issues in general, and specifically in older patients, especially when we have low body weight. And there are very specific drug dosing recommendations in the elderly in the package inserts. So at the end of this, we're left with the fact that it is time to get on this curve if you're slow like my partner.
All right, I'll use them.
And maybe slow like me. It's time to use the DOACs.
All right, so the next paper actually is an interesting food for thought, but it will be changing how you manage this in the hospital. So 75-year-old woman with fever and this leg. The question for you is, how many days of IV antibiotics do you think she's going to need? Or i.e., how many days is she going to sit in the hospital with you? Here are your choices. How many would say 24 hours? Few people. 3 days? A lot of people. 5 days? Depends where you work. And 10 days? Everyone's optimistic. All right, so there were 2 papers published this year in the New England Journal looking at these 2 new antibiotics that were used for the treatment of skin infections. And the advantage of these 2 new antibiotics is that they are once weekly dosing. And these were 2 non-inferiority studies comparing them to vancomycin. And given the fact that there are over 870,000 hospitalizations in the US every year for acute bacterial skin infections, once weekly dosing may dramatically change how we handle these patients in the hospital. So these 2 antibiotics, dalbavancin and oritavancin, they're in the same family as vancomycin. They're all lipoglycopeptides that basically disrupt cell wall biosynthesis. They have strong activity against many gram-positive pathogens, including MRSA, staph, strep, enterococci. The advantage of these 2 drugs is they have incredibly long half-lives. In fact, the drug levels stay above the minimum inhibitory concentration for staph for over a week. Now, both studies were very similar, but I'm going to focus on the dalbavancin study since the patients were slightly sicker and therefore more likely the ones that you would care for in the hospital. So in the dalbavancin study, they admitted anyone with an acute bacterial skin infection, cellulitis, major abscess, or wound infection, and they had to have a minimum of 75 centimeters squared of erythema. So for all of us Americans who are metrically challenged, but do think in terms of Apple and Android, that's about the size of an iPhone 5. They anticipated basically, any patient who was going to need a minimum of 3 days of IV antibiotics could be enrolled. They had to have a fever, a white count, or bandemia, and they had to have 2 at least of these features suggesting a pretty significant skin infection. And they could not have been on any antibiotics in the last 14 days. So they randomized over 1,300 patients. And this was a double-blinded, placebo-controlled trial. They randomized patients to dalbavancin, who got on day 1 a gram of dalbavancin, and again a second dose on day 8. But because it was placebo, they also received twice-a-day placebos for 10 to 14 days. After day 3, the treating clinicians who were blinded could decide to switch them to an oral agent, in this case it would have been a placebo. And after day 10, the clinicians treating them could decide to just stop antibiotics. But all patients had to get at least 4. They could stop after 10 days, but everybody finished after 14 days. The vancomycin group got a gram or weight-based, again, Q12 hours, based on the discretion of the treating clinician. And they got that every day. After day 3, again, the clinicians could decide to switch them to an oral agent, linezolid in this case. And again, after day 10, they could decide to stop, otherwise they completed 14 days. And they got a placebo infusion at day 1 and day 8. So the 2 groups were very similar in age, with a wide range, all the way up to 85. About 13% were diabetics, 15% were drug users, over 50% had cellulitis, which meant the rest of them had the major abscess or wound infection. 85% had fevers, and over 50% met SIRS criteria. So these patients were fairly sick. And the area was basically of redness was really about 2/3 the size of a piece of paper. Their outcomes, their primary outcome was an FDA-approved outcome for skin infections, and at 48 to 72 hours, it was the cessation of the spread of the redness and no fever readings times three independent times, 6 hours apart. Secondary outcomes was a sensitivity analysis looking to see if there was a decrease in erythema at 48 to 72 hours. And clinical success was deemed by the blinded study investigators after 14 days of therapy. And then they did a safety profile. So their outcomes here, you can see, this was a non-inferiority study, but when you looked at the dalbavancin to vancomycin at 48 to 72 hours, the cessation of the spread of erythema and no fevers, both groups were 79%. In a non-inferiority study, as long as there's less than a 10% difference, dalbavancin here is deemed non-inferior to vancomycin. In the sensitivity analysis, looking at the decrease in erythema by 20%, both groups were 88%, and they were very similar in their clinical success at 14 days. 11% of the patients had documented MRSA, and they had very similar outcomes. And in terms of deciding when to stop antibiotics, the clinicians who were blinded stopped the antibiotics at 10 days more in the dalbavancin group than they did in the vancomycin group. Safety, I mean, you're giving this drug and it's going to hang around for a week, so you really don't want people going home and dropping. So in truth, the safety events were actually very similar. In fact, the blinded adjudication of the events, they felt there were more safety events in the vancomycin group. Now, most of them were itching, pruritus, and diarrhea. The serious outcomes, there were very few. There was one anaphylactoid reaction in the dalbavancin group and one death, and there were 7 deaths in the vancomycin group. So takeaway on this, well, it is a non-inferiority study, right? So if you leave out patients or leave out information, you can make 2 drugs look similar. But in this case, it really does look like these once-weekly antibiotics are non-inferior to vancomycin. They cost a lot of money. The oritavancin only has to be given once, so it's a little less expensive. But if you start to think about how many days you can shave off the hospitalization, the cost may actually come down because we're reducing hospitalization. So these have now been FDA approved for the treatment of acute bacterial skin infections, and they are actually going to start testing them against other gram-positive infections.
So does your cardiac arrest team look like this? That's me on the left. So as you know, this is the cast of the 90s hit series ER. And in 1996, there was an article in the New England Journal that analyzed CPR events on television. And not surprisingly, if you've ever watched ER, 75% of patients survive CPR events on television. And 2/3 of them walk out at the end of the episode out the door of the hospital. Now, I don't know about you, but that's not exactly been my experience. But it does raise the question of if people are used to watching CPR on television, what happens when they watch it live? And that question was raised in this study that came out in 2013. This was a French trial of 570 family members who were enrolled in this trial, of family members of folks who underwent an out-of-hospital CPR event. So they were around when the CPR was going on. And they were randomized to either being invited to actually stay and watch, and 4/5 of them took them up on it, or to no specific invitation was made, and about 40% of them decided to stay anyway. This study then followed them out at 90 days to see how they were doing. Well, there were about 30 patients in the intervention arm and about 60 patients in the control arm who dropped out. And the authors make the point of saying that most of the dropout was related to people unwilling to talk with the researchers due to emotional distress. The patients, the family members and subjects of the trial had very similar baseline characteristics. Interestingly, they even looked at things like religion and marital status for how they would be doing going forward, and they were well matched, they were well balanced, rather. They then went on and did a psychological assessment of these patients, these family members, rather. They looked at the impact of event scale, which is a scale that looks for the presence of PTSD, post-traumatic stress disorder, symptoms. And they also looked for the presence of anxiety or depression symptoms through this other scale, the hospital anxiety and depression scale. And here's the data. Now, I know that's a lot to focus on, so I'm going to draw your attention to these 2 areas. At 90 days, there was a statistical reduction in PTSD symptoms and anxiety symptoms in the intervention arm. That is the group that was invited to stay and watch. But 90 days is not that long after a traumatic event, and maybe this finding won't have any durable legs. What about longer term? So that's the article from 2014 that I want to take you to, which is the one-year follow-up of this cohort. They looked at this same population of family members at 1 year, and again applied the impact of event scale looking for PTSD symptoms, and the scale looking for anxiety and depression. They also looked at a scale for complicated grief being defined as grief events that were longer, deeper, and more functionally impairing than would be considered normative. And they also looked for the evidence of major depressive episodes, not just depression symptoms, but a major depressive episode based on DSM-IV criteria. What did they find? Well, they looked at the original intention to treat cohort, the 570 members, but only 408 members at this point were willing to participate going forward. And there was basically equal dropout by this point in each arm. And I will tell you that the researchers said that if we don't have data on you, we assume you had PTSD. That's how they made the assumption to bias towards the null hypothesis. The control group in this analysis had an odds ratio of 1.8 for PTSD symptoms. So that's a lot more PTSD in the group that didn't have the opportunity to be asked to watch the CPR. Now, when they looked at just the folks who actually filled out the survey at 1 year, the intervention group had much fewer PTSD symptoms, depression, major depressive events, and complicated grief, with 30 to 60% roughly reductions in these major outcomes. So the effect was not only prominent, it was durable at 1 year. So what do we take away? Well, giving families the choice to watch CPR durably reduces PTSD, depression, anxiety, and episodes of complicated grief. But this is out of hospital. Does it apply to in-hospital? I would venture to guess it does. And maybe it is time to start asking families if they want to stick around when we're resuscitating a family member with CPR. And so that's it. And I want to thank you all.
Wait. I snuck in one more article because you hit me too many times with that snowball.
Fine.
So this is a landmark article from the BMJ published in December that proves a theory, or provides evidence to a theory that every woman in this audience knows, the MIT theory. And I don't mean Massachusetts Institute of Technology. I mean the male idiot theory, like wearing a Hawaiian shirt on a stage. So this BMJ paper looked at the sex differences in idiotic behavior by looking at the Darwin Awards. So for those of you that don't know, the Darwin Awards were named after the father of evolution, Charles Darwin, and it is awarded to anyone who shows a astounding application of common sense, who therefore causes his or her own demise and therefore eliminates themselves from the gene pool, doing all of us a big favor. In fact, one of the winners was a terrorist who posted a letter bomb with insufficient postage. And when it was returned to his house, he opened it. So when they looked at who won the Darwin Awards, they looked at 318 people who won the awards in the last 20 years. And which gender do you think it really was? So in conclusion, what we learned today, expect to be using neprilysin inhibitors real soon for heart failure. Don't back down if your patient's going to benefit from a venous contrast CT. Consider polyethylene glycol for hepatic encephalopathy. Stop non-selective beta blockers after a patient develops SBP. And expect to be using dalbavancin or ritonavir for skin infections, and watch your length of stay drop.
Yeah, not so fast. I get the last word on some things, but probably not here. So make sure that you measure delirium, or think about starting to use that CAM-S scale. And for the folks who have high CAM-S scores, think about palliative care and goals of care discussions. Or better yet, just prevent delirium entirely by using drugs like Ramelteon or maybe melatonin. It's time to really question the use of VTE prophylaxis in medical patients, and maybe the society can help us do that. It is time to get on board with these novel oral anticoagulants, even in my grandmother, And finally, I think it is time that we get rid of the old habit of shooing everybody out of the room the minute the code bells go off and offer families the opportunity to watch CPR. And with that, Kathleen and I would like to say thank you.